It is given as either 5 mg daily or 35 mg weekly. Overdoses causes hypocalcemia. Risedronate has reduced gastric side effects and is effective in a dose of 5 mg daily or 35 mg once a month. Zoledronate is used therapeutically once a year as IV infusion of 5 mg over 15 minutes, but osteonecrosis of the jaw and visual disturbances are the major side effects. Calcitonin is a peptide produced by the thyroid C cells. It inhibits osteoclastic activity and inhibits bone resorption. It is given as nasal spray at a single dose of 200 international units daily for 3 months. Nasal spray causes flushes, rhinitis, allergic reaction, and nasal bleeding. Reduces the incidence of fracture by 30%. Strontium granulate given 1 to 2 gram daily orally increases bone mineral density by 50%. However, it is very expensive, not easily available. Clonidine is an imidazolidine derivative used to treat hot flushes. It is also effective in hypertensive women not responding to estrogen. Not every menopausal woman needs HRT. A symptomatic woman due to estrogen deficiency requires HRT for 3 to 6 months. The duration and route of HRT depend upon the purpose for which the therapy is prescribed. Total duration of prophylactic therapy beyond 8 to 10 years has not proved beneficial, but the side effects may harm the woman. Benefit of the therapy should be balanced against the risk of breast and endometrial cancers, venous thromboembolism. Phytoestrogen is available as Femaril, 1 tablet to be taken twice daily. Therapy should be individualized according to the need. Risk of breast cancer is not increased up to 3 years of HRT and 5 years of estrogen alone replacement therapy. Lower risk is seen with the use of dydrogesterone in HRT. HRT can cause recurrence of breast cancer and is therefore contraindicated in women who has been treated for breast cancer. Tibolone is safe. HRT increases the density of breast tissue and impedes screening program of mammography subsequently. Breast cancer develops following HRT is of low grade with good prognosis. Endometrial carcinoma. ERT can cause well differentiated carcinoma of the endometrium. Minimum of 12 days progesterone added to the estrogen replacement therapy reduces the risk of endometrial cancer to 2%. Combined estrogen and progesterone provides a better protection against endometrial cancer. Tibolone is a safe drug and does not cause endometrial hyperplasia. Raloxifene, unlike tamoxifen, exercises anti-estrogen action on endometrium. The risk of cancer with ERT is dose and duration dependent. Premature menopause. Premature ovarian failure. Premature menopause is defined as the ovarian failure occurring before age of 40 years. It is clinically defined as secondary amenorrhea for at least 3 months with raised FSH or LH ratio, low E2 levels in a woman younger than 40 years. Incidence is 1%. Etiology. Causes of premature menopause are fewer germ cell migration from the yolk sac, more apoptosis of the germ cells, as in genetic disorders such as chromosomal anomalies involving the X chromosome. Ovarian dysgenesis is seen in 30% cases. Autoimmune disease reported in 30 to 60% cases. Mumps, thyroid dysfunction, hypoparathyroidism, and Addison disease may account for few cases. Ovarian biopsy shows infiltration of the follicles with plasma cells and lymphocytes. Raised CD8 count and low CD4 count suggest an autoimmune disease. Anti-ovarian antibodies are present. Tuberculosis of the genetic tract involving the ovaries can cause secondary amenorrhea and ovarian failure. Smoking is known to induce premature menopause, and the age when it occurs depends upon the degree of smoking. It is toxic for the follicles. Radiation and chemotherapy can cause premature menopause, but the effect is reversible and the ovary may resume ovulation and menstruation about after a year of amenorrhea. Alkylating agents are strong inducers of premature menopause. Ovarian failure following hysterectomy is known to occur in 15 to 50% cases even when ovaries are retained and is caused by kinking blockage of ovarian vessels. Tubectomy can also produce a similar effect. Prolonged GnRH therapy may lead to ovarian suppression and failure. Enzyme defects such as 17 alpha hydroxylase deficiency, galactosemia have adverse effect on the oocytes but more often cause primary amenorrhea. Resistant ovary. This terminology is used less frequently these days, and it is presumed that the follicles fail to respond to gonadotropin stimulation. Induction of multiple ovulations in infertility can cause premature menopause when the follicle gets exhausted. Pathophysiology is either exhaustion of the primordial follicles in the ovary or lack of receptors. Presence of antibodies has been described as a cause of premature ovarian failure. Clinical features include hot flushes, sweating occurring in 75% cases, may be more severe than natural menopause. Libido is diminished in 10 to 20% cases. Vaginal dryness, urinary symptoms are less complicated. Investigations include FSH 40 milli international units per ml or more, E2 levels of 20 picogram per ml or less, thyroid function, calcium level, chromosomal study, and thyroid antibodies, blood sugar level, MRI, pituitary fossa for presence of any tumor. Bone mineral density study is not always necessary. Ovarian biopsy, ultrasound, and prolactin levels are done. Complications: the risk of osteoporosis, cardiovascular disease, increase in premature menopause. Management: the cause of premature menopause should be ascertained and should be treated. Follicular maturation, ovulation, menstruation have been restored following the treatment of the cause. Oophoropexy, ovarian shield during the radiotherapy can protect the ovaries. Corticosteroid therapy is effective in autoimmune disease if the antibodies to sex hormones are present in the blood. Plasmapheresis has been attempted. A woman with hypoestrogenism may require HRT or other drugs to prevent osteoporosis. Estrogen implant with oral progesterone or Mirena IUCD offers long-term HRT. Specific management according to the need is: an older woman or parous woman not interested in pregnancy or menstrual function may require HRT if she develops menopausal symptoms. She may require prophylactic HRT if she is a high risk case of cardiac complication or osteoporosis. Libido improves with testosterone and E2 therapy. A woman not interested in pregnancy but requests for restoration of menstrual cycles should receive combined estrogen progesterone cyclical therapy. A young woman interested in pregnancy should be offered either ovulation induction therapy or offered donor eggs for in vitro fertilization. In a young woman with diminished ovarian reserve, dihydroepiandrosterone DHEA 25 mg plus folic acid overstored 3 times a day for 4 to 6 months and stimulation of the ovary improves the pregnancy rate 30 to 50% by increasing the oocyte and embryo quality. It also reduces the aneuploidy in the embryos. Late menopause. It is defined as a condition in which menstruation continues beyond 52 years of age. Late menopause occurs in women who have fibroids and is seen in women who develop endometrial cancer. Often it is constitutional. Beyond 52 years, endometrial biopsy is required to rule out endometrial pathology. Benefits of late menopause are late aging, better quality of life, it's cardioprotective and there is delay in osteoporosis. Disadvantages are increased risk of breast, uterine and ovarian malignancies. Postmenopausal bleeding. It is defined as any bleeding from the genital tract after 1 year of menopause. Normally, a 1 year period of amenorrhea after age of 40 is considered as menopause. However, vaginal bleeding occurring any time after 6 months of amenorrhea in a menopausal age should be defined as postmenopausal bleeding and investigated. Even without amenorrhea or irregular bleeding, if a woman older than 52 years continues to menstruate, she needs investigation to rule out endometrial hyperplasia and malignancy of the genital tract. Causes of postmenopausal bleeding are: vulval causes include trauma, vulvitis, benign and malignant lesions of the vulva, vagina, foreign body such as ring pessary for the prolapse, senile vaginitis, vaginal tumor, benign as well as malignant, post-radiation vaginitis, cervical erosion, cervicitis, polyp, cubitus ulcer in the prolapse, cervical malignancy. Uterus, senile endometritis, tubercular endometritis, endometrial hyperplasia, polyp, endometrial carcinoma and sarcoma, mixed mesodermal tumor. Malignancies include carcinoma endometrium, carcinoma cervix, carcinoma ovary, carcinoma of the vulva, vagina, sarcoma of the uterus. Benign causes are endometrial hyperplasia, endometrial polyp, fibroid, decubitus ulcer. Infections like pyometra, tuberculosis, senile vaginitis, senile endometriosis, bleeding from urinary tract or anal canal, irregular intake of HRT. uterine polyp endometrial hyperplasia, a fallopian tube malignancy, ovary, benign ovarian tumor such as Brenner tumor, granulosa and theca cell tumor, malignant ovarian tumor, blood dyscrasias, urinary tract causes like urethral caruncle, papilloma, carcinoma bladder may be mistaken for genital tract bleeding, bowel, bleeding from hemorrhoid, anal fissure, and rectal cancer may be misleading. Clinical features include the history, age of menopause, history of taking estrogen and tamoxifen should be elicited, abdominal pain, foul smelling discharge are noted in malignant tumors. Urinary and rectal symptoms are also important features to be noted. Examination, the BP recorded general examination include BMI, obese women are prone to endometrial carcinoma, abdominal palpation with removed tumor or ascites. Speculum and bimanual examination may reveal an obvious cause in the lower genital tract, such as cancer cervix. Investigation. Excluding the malignancy is the main aim of investigation. Blood count and smear will reveal blood dyscrasia, sugar levels, cervical cytology and cervical biopsy from the obvious lesion, endometrial tissue sampling, sonosalpingography for any endometrial polyp, ultrasound. Endometrial thickness more than 4 mm indicates the need for endometrial biopsy. Carcinoma CA125 serum levels. Several methods are now available to obtain endometrial for histological examination. Some are DNC, fractional curettage comprising of separate scrapings of endometrium and endocervix not only allows the exact site of malignancy if present but also detects the extent of spread, tumor and staging. The curettage requires general anesthesia and hospitalization. Uterine cavity aspiration for endometrial sampling may be done as outpatient procedure and has the additional advantage of avoiding anesthesia. Hysteroscopy plus EA. Vibra aspirator, gravel jet washer, Isaac aspirator, Pipel aspirator are used to obtain endometrial sampling. Hysteroscopic visualization. To improve the predictive value of endometrial study, hysteroscopic inspection and selective biopsy are now considered the gold standard in the diagnosis of endometrial lesion. Though 1 to 3% negative findings are also reported, false negative findings are reported. Ultrasound, CT, MRI, transvaginal ultrasound is an adjunct to other investigation in detecting the endometrial thickness, irregularity, pelvic tumor. In case endometrial cancer is detected, CT and MRI are useful preoperative investigation, and these detect the extent of spread of the tumor to the myometrium and the lymph nodes. Doppler ultrasound with increased diastolic blood flow and row resistant index suggests malignant growth. When the genital tract as a cause of bleeding has been excluded, cystoscopy, proctoscopy may discover the cause of bleeding in the rectum or bladder. Management. Treat the cause. When no cause is found, if there has been only one bout of bleeding, the patient should be kept under observation. About 80% of these cases do not bleed again. If the woman continues to bleed or the bleeding recurs, it is advisable to perform a laparotomy and hysterectomy. An undiagnosed small tumor may be discovered and dealt with appropriately. Otherwise, abdominal hysterectomy with bilateral salpingo-oophorectomy should be performed and the specimen should be sent for histopathological study. Flowchart for investigation post-menopausal bleeding. History and examination should be done. Growth on the cervix may be carcinoma cervix, so a cervical biopsy is taken and treat according to the stage. If cervix looks normal, pap smear is taken. Transvaginal ultrasound for endometrial thickness is done. If greater than 4 mm, endometrial biopsy by dilatation and curettage is done. Endometrial thickness less than 4 mm, follow-up. Endometrial biopsy for recurrent episode, endometrial biopsy for high risk cases is done.